Hi, my name is Kelly Saxton. I'm a dual credentialed practitioner in State College, Pennsylvania. I'm a licensed athletic trainer and massage therapist. I will be going over some of the more specific anatomy and physiology of craniosacral therapy. Usually, this PowerPoint takes me about an hour and 10 minutes in a live class, and I only have 30 minutes, so we're going to be skipping some slides and moving fairly quickly. If you have any questions, feel free to reach out once we get to the contact page. Cranial was first discovered by William Sutherland, who's a doctor of osteopathy in the early 20th century. He did some pretty primitive research studies, and then John Upledger ran with it in the 1970s. He was assisting with a surgery where his job was to hold down the dura mater while a physician scraped the plaque off of it. And he noticed that the system had a fill and empty at a regular rate, and sparked enough interest that he started his own coursework and research at Michigan State University. A lot of it was working with autistic children. He later opened his own institute in Florida, teamed up with the NFL, U.S. Military, Brawl Institute, Chickley Institute, among a lot of others. And it's still an active institute today, even though he's since passed away. Looking at the anatomy specifically, when you look at a U.S. anatomy book versus a European anatomy book, there's a disconnect there about whether these suture lines are fused or not. We tend to follow the more European outlook that these are living joints because they are full of Sharpie's fibers, blood vessels, nervous tissue, and there is a measurable movement. The only ossification is those embryological sutures. So if you were to touch your forehead, you could probably feel a valley of where your forehead was in two pieces, and those came together and fused to make your frontal bone. There's little islands within these suture lines called Wormian bone, and we're not going to worry too much about those. But the colored bones on that skull are your physiological system, and then the facial bones are the non-physiological. The difference being that your physiological system has the dura mater actually blends into the periosteum of those bones. And so you can use those bones as handles working with cranial to manipulate that tissue. Your non-physiological is just as important and plays such a huge role. And we'll go over how that attaches to that system. And we'll go over sphenoid is king on another slide. But just looking at the difference between an infant skull and an adult skull. And that's why I took the pediatric course, is to make sure that I was really working an infant in the most ideal positioning because their skull is so much different. There's the hard palate. This is an area that is often overlooked in manual medicine. Looking at how the hard palate and the palatine come together in the upper right picture, that palatine has big time nerve passageway from trigeminal. It also connects to the sphenoid. And then if you look at the picture below, the vomer, how it has a tongue and groove position onto the sphenoid and the palatine, that's pretty interesting. And that plays a large role in airway and even with anxiety. And then looking at the tongue in relationship to the hyoid has a pretty extensive muscle group called the suprahyoid that comes up underneath the tongue. Second group comes back, your retrohyoid attaches on the upper cervicals, your cranial base, and sphenoid. And infrahyoid goes down to the upper extremity, chest, and ribs. So working with upper cervical pain, even non-responsive disc pathology, I've had really great success working underneath the tongue. There's a fascial line that goes from the tongue all the way down the anterior spine. Think about how much you use your mouth. It's your avenue of expression. Speech, that's how we love. Breathing and eating. So if there's a dysfunction there, it could be something that would affect you globally. There's also a school of thought that your mouth has a similar shape to your pelvis. And so I've seen some connection there between mouth dysfunction and pelvis dysfunction. Looking at the mandible, how that non-physiological system comes into the physiological system, and looking at that articular disc specifically at the head of the mandible. There is a small muscle that will pull that disc in and out of position as your jaw opens and closes. So that's essentially what TMJ is looking at that joint position and how that articular disc is moving. But from a cranial perspective, there's a lot that plays into that joint. Your hard palate, jaw alignment, temporal bone alignment, your zygoma, ethmoid, vomer, nasal bone, all of that can play a huge role into that, as well as occiput. I do take a pretty extensive dental history with cranial. It can really give you some bigger information, especially if they have implants and bridges and things like that. Looking underneath the skull into the meninges and the intercranial membrane, your dura mater attaches directly into that periosteum of all your cranial bones. Again, that's what makes cranial what it is. You're using these handles to manipulate this meninges and other central nervous system tissue by pulling on these skull plates and releasing the sutures where these skull plates come together. The arachnoid space is in that spider web space, was where the cerebrospinal fluid bathes the central nervous system. And then your pia mater attaches to the brain via the arachnoid trabeculae. It's not pictured here. We won't go too much into it today. And then it folds in on itself, creating the intercranial membrane. This is the intercranial membrane. If you look at the picture to the right, where that darkened tube area is, and following those lines down to the convergence of sinus in the posterior, and it runs down the sigmoid sinus out of the jugular foramen. This is 70 to 75% of the blood return from your brain to the circulatory system. And the exit at the jugular foramen is an area that's often injured in whiplash. There's also 3 cranial nerves that exit there. All the cranial nerves for your eyes, other than optic, pass through this tentorium cerebelli. So doing ear pulls and working the sphenoid directly can actually manipulate this tissue. There is a pretty neat unembalmed cadaver study looking at the ability to manipulate this tissue by pulling on the ear, and they found some pretty great stuff with that. Here's where the dura mater attaches into the periosteum of other structures within the system, making these really good handles for doing these lifts and maneuvers. So you have all your cranial bones, the foramen magnum of the occiput where your spinal cord comes out, C2, C3, S2, the coccyx, and then it actually extends onto all your dural sleeves of your nerve roots and your cranial nerves. And we've already talked about the intercranial membrane. So if I'm pulling on your parietal bone and you start to get sensations down your right leg, the reason you're getting that is because I'm pulling on this continuous piece of tissue, your intercranial membrane, all the way down to that nerve root that may have like a sticky spot somewhere along that nerve pathway and is giving you the sensation in your leg. It's important to understand fascial tissue in order to understand how cranial works and why it's such a slow, light touch modality. Fascia is made up of 3 parts: collagen, elastin, and water. Collagen gives the tissue stability and more structure, and it reacts to slow, steady force, which is what cranial is. It's a light touch, it's very slow moving, and it's a very steady pull and holds. Whereas elastin is more of that quick rebound. Excuse me. And then water is a huge conductor of electricity, hydrates the tissue, brings in nutrition, and gets rid of metabolic waste. So if you think about a sponge, is it easier to tear a dry sponge versus a wet sponge? The dry sponge. So hydration is obviously a huge role in this. And then that conduction of electricity, that's why they also call it the primitive nervous system, because potentially that's what nerve impulse is moving so quickly and communicating so fast. The example of touching a hot surface. that is actually traveling through your fascial system rather than your peripheral nervous system. And that's why you can pull your hand away so quickly. And then looking at the top diagram of the biotensegrity model, so these hard wooden sticks would be representative of mostly collagen. Elastin would be more of these rubber bands. And the reason that, because it's made of collagen, elastin, and water, simply smashing the biotensegrity model will rebound into its original position. You have to use a triplanar position in order to manipulate this tissue, meaning it's a combination of flexion and extension. Side bend left or right, rotation left or right, or a shear, holding for a long period of time in order to get this tissue to change. Check out Strolling Under the Skin on YouTube. You can actually see water droplets running down this fascial tissue or this biotensegrity model. You can see blood vessels. You can see nervous tissue moving in and out of this fascia. It's really interesting. Excuse me. This is the ventricular system. It's a hollow area within the brain that's full of cerebral spinal fluid. And the main point of this is to show you the fourth ventricle. It's this diamond-shaped piece down here. That's one of the main areas that cerebral spinal fluid is made. And that's why we do this C4 positioning with cranial vault hold number 4, because of the close proximity to the fourth ventricle. This slide shows how cerebral spinal fluid is made and how the cranial rhythm is produced. Fluid is produced mostly in the fourth ventricle. There's a nerve that runs up to a stretch receptor in the sagittal suture. So if you touch the front of your head, running your fingers to the back between your two parietal bones, you should feel a valley. That's your sagittal suture. As the fourth ventricle makes fluid, this is a closed hydraulic system. So as that fluid, or semi-closed anyway, as that fluid fills, it creates a pressure and expands the skull. So as the skull expands and that sagittal suture starts to separate, that stretch receptor gets signaled at its max capacity. At that point, it signals fourth ventricle to stop making fluid. There's a continuous reabsorption rate of cerebral spinal fluid at the arachnoid villi down the cord. At the cellular level, capillaries meet that arachnoid villi. So it's like a bathtub with a towel shoved in the drain, and there's a constant drip coming out all the time. So as the level of the bathtub drops, the sagittal suture comes back together, and that stretch receptor, the sagittal suture touches, and it tells fourth ventricle to turn on and start making fluid again. Or in our bathtub example, it turns the shower on and refills the tub. It's the same thing that we just talked about. The rhythm is measured in squares, so symmetry left and right. The quality, amplitude, how grand and how big is that flexion versus extension, and the rate, is it actually a 3-second fill, 3-second empty. Here's a look at how sphenoid's king, especially with that occiput. Those two joints are actually a synovial joint, like a finger or a knee. So it's designed for movement. So in flexion, the sphenoid and the occiput open like a clamshell. And that same movement happens at every vertebrae, all the way down to the tailbone, and all the tissue connected. So you can actually feel this cranial rhythm anywhere in the body, but especially great right at the sphenobasilar junction. So there's an example of flexion, how the skull widens and moves laterally, and extension comes together. This is where I may lose a few of you, but understanding what is actually palpable under each finger. Let's start with the blue picture. That's a picture of the brainstem and how it's located directly behind the ear. And jumping your finger around the ear, you could isolate or put intent into different structures to potentially feel the rhythm of those structures within the cranial system. So, dead center, we're right at the pons of the brainstem. If I were to move my finger posterior, I'd be on hindbrain. If I would move above the ear, I would be on the limbic system, mammalian brain. And if I put my finger slightly forward of the ear, then I'd be in forebrain. And then the picture to the left, each finger is on a different structure. So the index finger is on the greater wing of sphenoid. The middle finger is on the temporal bone. Ring fingers on mastoid, so that's monitoring the flare of the temporal bone. The pinky's on the occiput and the thumb's on the parietal. So what really makes a great cranial therapist stand out is their ability to monitor all these structures and do a triplanar stacking of each of those fingers. If you can move on to doing that with 10 different structures, you're really getting a great bang for your buck if you have a clinician that has that ability. Here's a look at that triplanar positioning again if I kind of lost you. So that's sphenoid on occiput, that's sphenobasilar junction, and holding that triplanar position in flexion or extension. Holding that, so let's say we hold flexion, adding a left side bend, a left torsion, and possibly a shear into a position of ease first until the tissue, you see a little bit of tissue release. Then you can slowly move it into this position of restriction. When you work in the position of ease, you dampen the central nervous system response. It decreases pain. It decreases spasm. It increases blood flow. It increases fluid flow, the lymphatic system, all of that good stuff. So then when you move into the position of restriction, there's not as much pain and dysfunction. There's not as much restriction. It's easier for the body to accept that position. This slide looks overwhelming, and that's on purpose. Looking at all 12 cranial nerves, so you have them bilaterally, so you have 24 total. The point is that cranial is a really great modality in the treatment of traumatic brain injury or concussion. I'll just run through a few of them just to prove a point. So if you look at oculomotor, trochlear, and abducens, those all move through the tentorium. Those are all nerves that would feed eye movement or pupillary movement. Look at trigeminal. It's actually in three traditional branches, V1, 2, and 3. There's a fourth branch, the meningeal branch, that actually feeds the sensation of the meninges or the brain. So if like a client comes in and says, I had a concussion and my brain physically hurts, I'm going to start thinking trigeminal and where are all the places that trigeminal goes. Lacrimal gland, have you ever heard of a cluster headache? There's a lot of tearing with a cluster headache. So again, how is that trigeminal nerve being put on tension, or what bone is in a triplanar position that could be released in order to get that tearing to stop? Looking down at 10, 11, and 9, 10, and 11, those are all the nerves that exit with that sinus that we talked about with the intracranial membrane through the jugular foramen. So if someone comes in with difficulty swallowing after a concussion, they've got some vagal nerve symptoms, maybe they've got some gut disruption, and they have a lot of neck pain, I would suspect, especially if they had a whiplash injury, that jugular foramen is probably an area that needs to be treated. Here's a picture of that jugular foramen and that sigmoid sinus exiting with this green right next to the occiput. So the occiput meets the temporal bone. There's a suture line here, so we could do different techniques to work on that. Here's your vagal nerve, this yellow nerve that travels way down into the gut. So that's your gut-brain connection. Remember, a cranial nerve, there's no synapsis. It is a continuation of the brain itself. So your brain is literally in your gut in this situation. The polyvagal theory is very interesting. If it's something that you are interested in reading about, I would check out YouTube for some quick videos. There's really great books out. Here's a picture of the gut-brain connection. I drew it on my son. These first two ganglion are, there's no synapses here directly from vagal nerve. When you get down to the IG ganglion and then the hypogastric ganglion, there is a synapses, but they are all indicators of whether there's a gut-brain connection dysfunction there, how depending on how tender they are. And there's different treatments that you can do there. So what is cranial good for? The answer is, what does your central nervous system control? Everything. There's very little that it can't treat. Again, it's the skill of your practitioner and how well the person on the table's willing to open up. The things that I treat the most in the clinic are neck pain, TMJ, depression, dizziness, headache and migraine are definitely number one. Traumatic brain injury, concussion. Worked some with hearing, and then with kids, with pediatrics, all kinds of birth trauma, C-section. A lot of kids get chronic ear infections, colic, torticollis, nystagmus. I've had a couple kids, I've treated a couple with concussions. The sky's kind of the limit. It's really great bang for your buck. I threw this in here just because it's become pretty relevant to me working with children and starting to do this with adults also. Retained primitive reflexes are reflexes that a child develops in utero or in their first year of life. And it helps develop their nervous system, especially meeting goals like rolling, crawling, standing, walking, and then more so into speech, hearing, arithmetic, writing, reading, like the whole 9 yards. Example, a Moro reflex, an ATNR reflex. There may be a sensitivity to sound. They have a hard time with tags, sensory input with clothing, that kind of thing. So if these children are more locked into reptilian brain, this is what really keeps a human alive. This is respiratory rate, blood pressure, basic ambulation without reciprocation, if that makes sense. If you've watched a reptile walk, they waddle, they don't necessarily reciprocate. Limbic system is the next higher brain center. It's what can a dog do? Can they walk, sit, stand, stay? There's emotions there. And then the neocortex is what makes you more human. It gives you personality. It's understanding complex problems, reading, writing. So with children that come in that have not integrated these specific reflexes, they're operating at lower brain centers, maybe more reptilian brain or maybe mammalian brain, and they're not able to access this higher brain center. So through different positions of touch, working with cranial, getting some of those skull plates loosened up, and then actually doing these integration exercises, it's advancing these challenges with developing children. Contraindications, intracranial bleed, aneurysm. It's, if you're treating someone with a concussion, you might need a physician's note. Just make sure that they don't have an acute bleed. But there's more of just precautions. You don't do specific lifts. You don't do specific maneuvers if someone has a weakened alar ligament, herniated medulla, fractured C1 or C2. Make sure that you know how to test for those. We're going to skip this one. It's a pretty great documentary on energy medicine in general, but this kind of just touches on the emotional component of cranial, and I'm not going to spend a lot of time here because I only have 5 more minutes. But there is an emotional component to injury and illness. And I think we all need to be able to realize that and refer out when necessary. And if it does come up on the table, know that you have the ability to stop the session. You don't have to push them. You work at the client's pace. We're going to skip key concepts. And if you're still kind of on the fence about cranial, even though we've presented you the anatomy and physiology, check out the Upledger website. They've got tons of case studies and journal review articles. It's upledger.com. You can check out my website. I've got a resources page, or spend the $100 and go receive a treatment. Upledger has a find a practitioner option where you can type in your zip code and see who's available in your area. General rule of thumb, some people may go for more alphabet soup after a clinician's name. That doesn't necessarily mean that they're a good clinician. So, maybe if you try it the first time and you're not really sure if it's for you, maybe try a different clinician and a different set of hands. If you have any more questions about cranial, or you want to geek out with me some more, there's my contact information, my website, email, Instagram. Appreciate your time, and I hope that it's something that you try in the future.